To start our first session, let's all welcome our moderator, Ms. Ranjit Kaur.
Good afternoon, and thank you for inviting me to be a moderator for this session. It's a very interesting topic this time. The other big C on the darker side of cancer. And we have two interesting presentations. And I'm going to be moderating the session. Joining me as our reactor is Max Ventura of the AIA Philippines, ESG consultant. Would like you to take a seat over there. Thank you. A reminder to all who are listening, if you have any questions during the Q&A session, please do put in your questions in the chat box and we will get the speakers to answer. For this session, we will delve into the grit that comes with the battle. We'll talk about cost or cash, as some people put it. I would say cost, the other big C on the darker side of cancer, and presented by Dr. Nirmala Pathy and Dr. Corazon Ngelangel. Please do pay attention. You will have some interesting insights into cost, or the other big C on the darker side of cancer. So may I invite Dr. Nirmala Pathy to give her presentation. Please give her a big hand.
A very good evening. Thanks for the invitation again. I feel very honored to be here. It was fun. And this topic is very close to my heart because this is where I started realizing that rather than clinical outcomes, there's a lot of things that we can do to improve patient-centered outcomes. And that's because I had the honor of being the principal investigator for the ASEAN Cost in Oncology study. And that's how I started moving towards patient advocacy and fighting for things which are important to patients and their families. I think a common term, in the past, we used to talk about toxicity of treatments, and therefore we say cancer treatment, toxicity, and so on. And soon after, there was a new term that was coined, financial toxicity. And financial toxicity was initially thought to be a result of cancer treatment. But when we looked at what happened and what we found in the ASEAN Cost in Oncology study and a myriad of studies elsewhere, we realized that the cost is not necessarily due to cancer treatment alone. It starts from the point of diagnosis. Hence, we started saying that financial toxicity refers to the bad effects or the complications, financial complications of being diagnosed with cancer. I think today what we'll be doing is, like Ranjit has rightly pointed out, it's not just cash, but more like cost. And why do we say that? Is because patients have to fork out cash out of their pocket, but they also suffer from indirect costs. And what are those indirect costs? Loss of productivity and loss of income. And that's also a big component, something that was not something that we found in the action study. We were not able to show that. So I'm here to share insights on what are the other costs that we incur, that is incurred by patients and their families and caregivers as a whole. Just like I think we are reiterating what has been said before. When there is cost, the cost is not only for the patient, but for the entire household. The entire household suffers, and it impacts the family's future because they are using up their savings and so on.
When you say cost, and there are some hidden costs that you were mentioning, would you particularly want to sort of list down what are the hidden costs that you think you would recognize as?
Actually, some of it has been revealed through our qualitative inquiries with patients. So what we found in action study was all numbers, and we felt that some things were missing. So with the qualitative inquiries, we begin to realize that even when we talk about cancer treatment, if the cancer treatment is provided at low cost, for instance, chemotherapy, the recurring payments and the recurring need to move to the hospital and going back can be detrimental for families, not only because they need to spend, but also they lose time from work, and also for the caregivers. Caregivers are impacted. We never measure those things. Caregivers get affected far worse than what we can imagine. And only in recent times we have begun realizing that caregivers, we need to also pay attention to caregivers. So those are the long-term and recurrent need for payment, but also for supportive items like wigs, breast prosthesis. These are never covered in the insurance system in many places, you know, and the government.
Okay, now we talk about the other big C.
No, it's the wrong one.
What we can do, I think we can, I can speak. Because whatever that Ranjit has said is very much related to what we did with the qualitative inquiry. So I'll tell you all the story. So we did action study, and then we realized there were a lot of details which were missing, which is needed. Because we need to come up with some actionable solutions instead of always highlighting the problem. So we got together and gathered a group of people with cancer. Not only people with breast cancer, but also cervical cancer, colorectal cancer, prostate cancer, more than 100 of them, all qualitative inquiries. So it's loads and loads of conversations, but it was so meaningful, and we gathered a lot of useful information from there. So when we looked at costs, generally there were the direct medical costs, and these are things that we can always imagine, you know, like going to the hospital, paying for consultations, paying for surgeries, treatments. But the thing about this treatment is sometimes we don't realize that for surveillance, when patients need to be on follow-up for recurrence, there's this cost for imaging, and these are things that often are missed out. So people keep on having to spend those things, and some of it cannot be claimed from insurance, and it comes out of pocket. And then when we move on to indirect medical costs, let me move to non-health costs. Non-health costs is very important. Again, when we talk about health systems are not really responsible for the non-health costs, and therefore it is often missed off. And non-health costs includes things like, you know, getting food, getting transported to the hospital, getting someone to look after the children while the mom is sick, or getting someone to look after the parents. So there are a lot of elements that are missed when we just focus on cancer therapies and hospital-based care. So, and we find that even in settings where there is universal health coverage, meaning that a lot of treatment is provided at highly subsidized costs. So we realize that non-health costs is often missed, and no one advocates for non-health costs. And I think it's very, very important, especially in women with breast cancer. Because what is something that is accessible for women with resources, for instance, a mastectomy bra, may be something that is out of reach for another woman. And it's not that they do not want it, it's because they can't afford it. And these are the stories that we heard from our patients. And we thought that it's so important to highlight them, because often these are things that no one tells. It's untold stories, right? And in terms of indirect cost, that's where it becomes interesting, because whether a person is poor or rich or well-educated or not less well-educated, the fact that they lose productivity, the fact that they have to take medical leave, unpaid medical leave, because most of our countries, we do not offer very long-term cancer leave. This is again very much related to employment and employers, and it is not related to health systems. So again, the problem is all of us are working in our own sectors. And when we work in our own sectors, you don't see the other problem, or we feel that how am I going to change that? And that's how I think the link there is the patients and the patient support groups. Because it's easier for us to link to all of you, and all of you link us back with the other stakeholders. You know, like how Max is here today, you know, like, so usually we don't directly speak to each other, but it's because of a common interest of helping patients. So those are the indirect costs that we felt that is often missed out. And people don't quantify them. In recent times, we have started quantifying, counting. You know, when people get cancer, what is the indirect cost? What is the indirect cost for the patients, but also what's the indirect cost for employers? Only when we do that, people start paying attention. And we are not only talking about people who go to work and or people who don't go to work. That's much easier to calculate. It's much difficult to calculate when people go to work and they don't give their full ability because they are less productive. They are too sick from chemo, or they have problems remembering things, or they are too weak. They can't use their arms and things like that. So those are the things which we call as presenteeism. People are present, but they are unable to provide. So these are things that need to be calculated, and that's where the actionable solutions can come in, and we need multi-sectoral collaboration to work on it. So health systems alone cannot deal with the big C when it comes to cancer.
Thank you, Dr. Nirmala, for this very succinct information on health costs and non-health costs. We will now play the presentation by Dr. Ngelangel, and she would also explain the other aspect of costs when it comes to cancer. Thank you.
Okay, now we talk about the other big C on the dark side of cancer, cash. Funding finances the peso. The Philippine Cost in Oncology, or PESO study, described the economic impact of cancer on Filipino cancer patients using the ASEAN Cost in Oncology Action Study dataset. And it concluded that cancer can be a significant economic burden for Filipinos, leading to financial catastrophe. Insurance mechanisms at the time of the study failed to protect against catastrophe. The PESO study included 909 patients, 58% female, 75% married, mean age about 52 years, 76% had secondary or higher education, 46% were household heads, 32% spouses of the head, and 40% had no insurance at all. And those with insurance had, most of them had health insurance. Some had employment-based insurance, private insurance, and community insurance. At baseline, roughly 43% belonged to the two lowest income brackets, and at the end of the follow-up study, 63% belonged to these income brackets. So there is an increase in patients going into the lowest income brackets. Across a 12-month period, about 51% had a decrease in income, with 25% falling to the lowest income bracket. 35% had no change in income, and 14% had an increase in income. Belonging to higher income groups was significantly associated with lower risk of financial catastrophe. Insurance did not confer significant change in risk of death or financial catastrophe. At 12 months, the proportion of households who earned their income, such as crops, agriculture, sidelines, family businesses, and wage, decreased compared to baseline from 85% from 85% to 76%, while households who receive income through remittances and gifts increased from 14% to 23%. There was also a change in types of employment, with decreases in individuals involved in professional and sales and work corresponding increase in people involved in elementary occupations. There was a decrease in doing paid work and also doing housework. Now, what did the patients do to find funds for their treatment? From at diagnosis to month 12 follow-up, they sought assistance from family and friends, obtained loans, used their savings, sought financial assistance from government, and sold their assets. So from the action study and the PESO study, what has changed for the country since? The NICA the National Integrated Cancer Control Act was signed by President R. Duterte in 2019. In 2018, during a debate in the Philippine Senate, Senator Sani Angara, a co-sponsor of the NICA, drew on the findings of the action study to highlight the urgency of immediately passing the bill into law. This was a key factor leading to the quick and successful passage of the NICA within the year. The NICA is widely seen as a significant first step in the transformation of cancer care across all levels of the Philippine health systems. So the NICA Republic Act 11251 was approved in February 14, 2019. It is an act institutionalizing a national integrated cancer control program and appropriating funds thereof. The most important words there is appropriating funds thereof. So in Section 20, there is a provision for establishment of cancer assistance funds to support the cancer medicine and treatment assistance program. The DOH shall manage the fund in accordance with existing budgeting, accounting, and auditing rules and regulations, and shall make a quarterly report to the Office of the President and Congress. In Section 21, PhilHealth benefits for cancer was mandated. PhilHealth shall expand its benefit packages to include primary care screening, detection, diagnosis, treatment assistance, supportive care, survivorship, follow-up care, rehabilitation, and end of life for all types and stages of cancer, both in adults and children. Section 22 look at social protection mechanisms. The DOH, in collaboration with SSS, GSIS, Philippine Charity Sweepstakes, DOLE, DSWD, PhilHealth, and LGU, shall develop appropriate and easily accessible social protection mechanisms for cancer patients, people living with cancer, cancer survivors, their families, and carers. It shall aim to encourage the underprivileged and marginalized people living with cancer to undergo the necessary treatment care. In Section 32, this contained the appropriations, the funding for this program, Cancer Control Program. The amount needed for the initial implementation of this act, including maintenance and other operating expenses, shall be charged against the current year's appropriations of DOH. For the succeeding years, the amount allocated for the NICA in DOH budget shall be based on strategic plan formulated by the cancer, and the Council has already approved the 2020-2030 Strategic Action Plan for Cancer in the Philippines. The amount should be in the National Expenditure Program as basis for the General Appropriations Act. This figure summarizes the oncology fund flow in the Philippines. Sources of funds come from the government, PCSO, PAGCOR, sin tax revenue, central and local government revenues. These are pooled, going to DOH, PhilHealth, local health units, funding the whole cancer control continuum. While the U.S.A. Act and NICA mandate an increase in resources for health and cancer control, the guidelines on transition and interagency transfers from revenues of government-owned and controlled corporations have not been released. In the PESO study, no significant impact. Now we look at the PhilHealth as it is one of the major sources of funding for the cancer control program. In the PESO study, there is no significant impact of having insurance on financial catastrophe. It could be inadequate benefit package or support value given to the insurance scheme at the time. At the time, the insurance was under case rate system and covered only admissions, surgeries, and radiotherapy sessions. At the time of the PESO study data collection, the SAY benefit package covered only a limited number of cancers and the impact of the program. The program existed at the time of the study and covered all direct medical expenses, hospitalization, medicines, health services. It is estimated that the number of individuals who experience catastrophic spending would increase by 22% would decrease by 22% or from 369 to 286 individuals if the SAY package at that time could have covered all direct medical expenses. We look at the Philippine Insurance Corporations, the PhilHealth SAY packages in providing financial risk protection, and after the PESO study, and the conclusion was that the SAY benefit program was successful in reducing patient expenses and lowering the odds of financial catastrophe only during the first year of treatment. This may be sufficient for conditions with short treatment, but not for diseases warranting longer periods such as breast cancer, for example. Findings support the continuation and expansion of the program with consideration for increasing coverage periods for selected conditions. In the PESO study, we documented that the insurance can provide protection versus catastrophic disease. Insurance has been documented to provide protection against catastrophic disease in other studies. Healy et al. Concluded that the health insurance protects against catastrophic expenditure among acute stroke patients in China. Cook et al. Found that elderly among the elderly in the U.S. who experienced major diseases, including cancer and stroke, there was a median asset decrease of around 50% among newly ill uninsured compared to much newly ill insured elderly. Min and Tran found that in rural Vietnam, having one household member with an insurance card was significantly protective against catastrophic health expenditure and impoverishment. Lastly, in Korea, Kim and Kon observed that financial catastrophe among cancer patients decreased when cancer was included in the coverage plan. Now, from the action study, the one that the whole region ASEAN, what has changed for your country since? The ASEAN Cost in Oncology Action Study of the George Institute for Global Health and ASEAN countries Cambodia, Indonesia, Laos, Malaysia, Myanmar, the Philippines, Thailand, and Vietnam followed 9,514 cancer patients across 41 sites and revealed that 75% of them died or had suffered a financial catastrophe because their medical costs exceeded 30% of their annual household income. Diagnosis at a more advanced stage led to patients being 5 times more likely to die within 12 months. These deaths could have been averted through adequate investment in primary health care and cancer care. So, in the past years, the action study had helped improve cancer care policy and priorities across Asia, such as the NICA in the Philippines. Dr. Hashbola Trabrani in Indonesia said that in Indonesia there has been a good progress in covering cancer treatments in our national health insurance scheme, but it's still insufficient coverage. Economically, there has been much less prevalence of impoverished people who are suffering from any cancer in Indonesia. Cancer has been the second largest amount of claims in our NHI, National Health Insurance, after CBD. The next question is, in the Philippines, what solutions can the patients turn to when government can no longer provide? So lifting these private sources of private fundings from one slide I showed you a while back. So private employer coverage, employer insurance, private insurance, HMOs, life insurances, donor funds, NGOs, cancer-related NGOs, and individual and household funds. So again, they would use the funding, seek assistance from family, friends, obtain loans, sell assets. However, in the individual and household funds, the out-of-pocket expenditure should be less than 20% of household health expenditure, so that the family would not go into financial catastrophe. The private health insurance and the cancer-related NGO funding are also very limited. So government has to step in. From the Hope From Within organization, these were listed as governments who would be helping cancer patients in the Philippines, and the cancer patients and the public have to go to them, have to nudge them. DOH Medical Assistance Program, PCSO, Individual Medical Assistance Program, DSW, Assistance to Individuals in Crisis. PAGCOR also provides medical assistance. The Office of the Vice President also provides assistance. Senate of the Philippines and the House of Representatives also offer assistance. We just have to go to them and knock them. The LGU offices, Office of the Mayor, the governors, also congressmen. Aside from the congressmen, the House of Representatives can also offer financial assistance. Thank you.
May I now invite Dr. Corazon Ngelangel to come up and join me on stage along with Dr. Nirmala Bhoo. We now come to the Q&A session. So if you have any questions, you can ask, and we will get the speakers to answer. And my colleague, Max Ventura, will also be here to be the reactor for the session. Are there any questions from the floor? It can't be silence. It's a very important topic.
Hi, my name's Ting Zhang. I had worked in China for some of these access to medicine issues. One question I had in regarding all of this is there access to clinical trials that can alleviate some of the costs associated with treatment, or this is a different scenario?
We didn't get your question. Could you repeat and louder a bit?
Can patients with limited financial resources access to ongoing clinical trials?
Dr. Ngelangel, do you want to answer that?
Yes. Patients do have access to clinical trials in the Philippines. I think also in Nirmala's country, but I'm talking about the Philippines. Yes, there are. We do have, but it really depends on on the lung cancer side. Currently, the clinical trials ongoing in the Philippines are on breast, lung, lymphoma, melanoma, what else? This is situated mainly in the big centers. In Metro Manila, there's also one or two in Baguio City, in Cebu, in Davao, in Iloilo. So yes, patients do have access on clinical trials. Yeah.
Thank you for that. Yes, Mayan.
Mayan Solomon from ICANSERVE and Cebu based. I'd like to do a follow-up question, Doctor. Nothing was mentioned about malasakit. Now, in Cebu, some of our women, they go to PCSO, but then they are directed to malasakit. And in the presentation, we do not see any mention of malasakit. Please clarify.
Malasakit is basically a separate funding source from government. Okay, so we kind of connect it to the NICA law. In NICA, they have this Cancer Assistance Fund currently, which they also get some funds from malasakit. You get it? Malasakit kasi is operating in mainly in hospitals. Yeah, and it actually serves patients with low resource, any kind of disease. It can be cancer, it can be hypertension, it can be diabetes, and patients with cancer can go to them and also ask for assistance on medications, diagnostics, whatever actually. As long as they are in the hospital where they are asking where in the malasakit office is. Okay, not all government hospitals has a malasakit office.
Thank you for that. Max, is there anything you would like to say about have there been any changes in terms of insurance with the introduction of the Act that happened in 2019 from your perspective?
Yeah. Okay, so first of all, good afternoon to everyone. I'm really very happy to have been invited in this session because this is actually an intersection of two things I'm very passionate about, financial literacy and health and wellness, particularly in the battle against cancer, having had family and my wife deal with the disease. No? So I think I just would like to react to the statements and then go to the question of Ranjit. So essentially, what we would like to look at this is in terms of risk mitigation. So one of the best tools for us in terms of risk mitigation would be to have some sort of insurance, no? And that's what we have tried to develop as a company so that we can deliver on our brand promise of healthier, longer, better lives. So insurance plays a big role in terms of battling the disease and lessening the impact, the negative impact of draining your financial resources. So, but then a step before that would be really trying to understand your basic financial well-being. And we've been doing some trainings, and it comes as a surprise to many of our countrymen that the formula for saving is really income minus your savings equals your expense. Because more often than not, we operate in income less expense, whatever is left is savings, and more often than not, there's no savings left. So savings generation, I think, is an important tool in terms of mitigating the risk in the event that you do have to battle with cancer. Then the next question is, if we say that cash is king, I'd like to think that care is his queen consort, because if you care for something, then you will put the resources for that. So then at the micro level, for example, there are tests now, that genetic hereditary tests that gives you an idea of whether you run the risk of getting cancer, and it costs about 20 to 40,000 pesos. You drink Starbucks, you get 200 easily in a visit. You get 60 days, that's 6,000. If you cut by half your consumption, then you set aside funds to do the test, and that helps you navigate your health and well-being. How will you deal with the future? Now, at the macro level, and this is where I think we can try to address the questions raised by Nirmala about the indirect cost, how it impacts the patient. In our case as a government, and I'm glad that Dr. Cora mentioned about the National Integrated Cancer Control Law, which allocates or sets aside the cancer, special cancer fund. However, in our budget this year, that 500 million was taken out of the National Expenditure Program. So where will we get the funding to assist the patients? But then we get an Office of the Vice President that gets 500 million for confidential intelligence funds. So I'm saying, why not realign that and put it to where it counts, if we care, no? And precisely, that's what I'm advocating for, that to battle this issue on cash and the cost, I'd like to offer 3 C's as well. Us, citizens, if we, or cancer patients in particular, coalesce, we form our alliances, and then we campaign, we advocate for our cause, and especially in the budget of our government now. Because that's where primarily the bulk of the cash should be coming from. We already have our universal health care, and that should be funded. And the cash should be coming from government, from our taxes. So that's what I'd like to just share and react, because ultimately government will be able to address the indirect, help address the indirect costs as well. And insurance would play a big role, as was mentioned in your study, Doctora. Because I mean, in my case, I was paying for the premium. I haven't fully paid, but my wife had cancer, and we were given the cancer assistance because I got the cancer rider on her policy. And that's for a segment of our population. But for those who are on the marginalized sector, I think government has a role to play, and that's where I think the cash should be coming from.
Thank you, Max. Thank you very much for the clarity. I would like to now, for the last couple of minutes, I would like to ask Dr. Corazon and also Dr. Nirmala to just give your burning recommendation of how to overcome this whole issue of, as what Max says, cash is king. I say cost is an issue. It's an important issue, far more important than just being in the Department of Health. Beyond that, so if you could just give us a short remark to conclude this session.
You want to start? I think there's a lot of talks about the need for governments to step in, do more and stuff like that. So I wouldn't get there. I thought that I would like to focus to something that's very close to my heart, a result of what we found from Action Study and all the other subsequent studies that we did. And we think that financial navigation is a very important area that needs to be addressed. And it's not new. Patient navigation is not new, but financial navigation is a little bit different from patient navigation, because patient navigation is very general, and financial navigation has the opportunity to direct patients, counsel patients, connect them to financial resources, and also do more than just connecting patients to resources, but also support those who are even high income and middle income, because they need financial planning advice, they need debt consolidation advice, and these are things that financial navigation services can do. And in the US, there's a lot of financial navigation programs which are ongoing. In Asia, we have none, and it has to be tailored to the local setting. I think that's the most important. You cannot adopt from US and try to do it here. Our health system differ, the way things, so we have to start, and it has to be a co-design approach where investigators, academics work with the patient support groups and so on to come up with a program that works. Not too ambitious, start small, and move on and build up a bigger financial navigation program. I think that will be my
Thank you, Dr.
take.
Kara.
Yeah, okay. For the Philippines, actually the NICA law is, if you read it, it's really fantastic. And the IRR that was made for the NICA law also gave more details on how to implement the NICA law. Now, we have to make government, particularly Department of Health, and at the back of the Department of Health is the Department of Budget Management, because they're the ones sometimes at odds with DOH to be able to come up with funds to fund whatever is mandated in the law. And whatever is in the IRR, as I said, it really reads perfectly. I was a member of the IRR committee. Menchi Osti is here, he's also a member. So it's really nice, except that DOH must do what the IRR has mandated. And they have signed it. Their secretary has signed it, so it must be implemented, sentence by sentence, word by word, paragraph by paragraph. And they cannot question anything that is there because this is signed by the Secretary of Health himself. Okay, so meaning to say, please implement what is in the IRR. Now, for the Filipino citizens, the PhilHealth insurance, the public health insurance actually is fine. And what I know is PhilHealth is now kind of strengthening whatever it is there for the cancer patients, and we have to wait. The problem with the waiting is it takes time, and so we waited 30 years for the NICA law to come into LO. We can wait not 30 years for PhilHealth to really fatten up the packages for cancer patients. But the thing is, all Filipinos must indeed enroll themselves in the PhilHealth because it does help when you get sick.
Thank you very much. And with this, I would like to wrap up by saying the conclusion of this session is: 1, financial navigation; 2, don't look just at the Department of Health. You just can't be knocking on the door of the Department of Health, but the budget that is by the Ministry of Health or the Department of Finance, that's where you need to start from, because you need to get the allocation from there. And the Department of Health needs our help as well for that. With that, I would like to say thank you to my speakers and also to my fellow reactor, Max. And thank you to everyone for listening today. We had a good session, and with that, I end this session. Thank you very much.